posted for, or patients with respiratory disease posted for thoracic or lung resection surgeries. So both we'll have to discuss. So today we'll be discussing about a patient with chronic obstructive pulmonary disease, actually posted for a non-respiratory surgery. So we have with us Kavin and Ramnathan. So they're going to present the case. So once they present the case after the history, we are going to discuss about the history, then examination we'll discuss, then investigations and management. Okay, Kavin or Ramnathan, one of you can present the case.
So our patient here, name Mr. Gopal, age 45-year-old female, 45-year-old male, who is a driver by occupation, and his place of residence is Cuddalore. He presented with the chief complaints of pain abdomen for past 5 days. It was associated with nausea and vomiting for the past 2 days. History of presenting illness. Patient complains of pain abdomen in the right upper quadrant for 5 days, which was insidious in onset. The pain was intermittent, on and off pain, and associated with consumption of oily food. It was relieved spontaneously. There are no particular aggravating or relieving factors. Patient also complained of nausea and vomiting since 2 days. He had 2 episodes of vomiting, and the vomitus contained food particles. It was not bile stained or blood stained. Patient gives history of breathlessness for the past 5 years, which is gradual in onset, progressive, aggravated by exertion, and relieved on taking rest. Initially, patient had breathlessness only on hurried walking, which is MMRC grade 1, which has now progressed over the past 5 years to having breathlessness on walking less than 100 meters, MMRC grade 3. There is no history suggestive of there is no history on lying down immediately or at the night, by which the patient is woken up from sleep and is gasping for and is hungry for air. Patient was treatment for this breathlessness. Patient was started on inhalational drugs via inhaler, which he takes regularly for the past 2 years. History of cough with expectoration for the past 8. Patient complains of history of cough with expectoration for the past 8 years. He produces thick white mucoid sputum, approximately 1/4 to half a cup per day. It is associated with yellowish or greenish sputum twice a year for the past 3 years. During the last year, he required a hospital admission to the ward for treatment with IV drugs and inhalational drugs via nebulization, and chest physiotherapy and deep breathing exercises. There is no history of hemoptysis, loss of weight, loss of appetite, evening rise of temperature, night sweats, or history of taking a fixed dose of combination of medicine for more than 6 months. No history of fatigue, confusion, irritability, headache, or tremors. There is no history of swelling of limbs or abdominal distension. No history of chest pain, palpitation, or syncope. Past history: a patient is a known case of COPD on regular treatment with inhaled drugs for the past 2 years and required hospital admission twice in the past year. Known case of systemic hypertension for the past 2 years on regular medication with 1 oral medication, which he is taking once daily after food in the morning. Patient does not give history of increased cough after taking the antihypertensive medication. Not a known case of diabetes, bronchial asthma, angina, ischemic heart disease, or thyroid illness, or kidney disease, or history of jaundice or bleeding tendencies. Patient has no known allergies to medicine, dust, or food. Patient has no previous history of surgeries or exposure to anesthesia. No history of blood transfusions in the past. Personal history: patient is a smoker since the past 25 years and smokes around 20 cigarettes per day. Last smoked 5 days ago. So number of pack years is 25 and the smoking index is 500. A patient is an occasional alcoholic, drinks on events 1 to 3 times a year, moderate in quantity. Takes a vegetarian and non-vegetarian diet, has no history of recent alteration in bowel and bladder habits. Patient sleeps quite well. Family history, patient is married and has 2 children. No history of similar complaints in the family. No history of diabetes, hypertension, thyroid, asthma, or heart disease or cancer history in the family. Occupational history, he is a driver by occupation. He has not been working for the past 2 months because of his illness. And he also works as a mechanic and gives history of exposure to vehicle smoke on a daily basis. So summary of the history, patient is a 45-year-old male, driver by occupation, who is a chronic smoker with a history of exposure to vehicle smoke. He has come with complaints of intermittent right upper abdominal pain associated with nausea and vomiting. He is a known case of COPD on treatment with inhalational drugs and systemic hypertension on medication. Provisionally, he is a case of acute cholelithiasis with COPD.
Okay, well taken history, Dr. Ramanathan and Kavin. So coming to your introducing the patient and regarding this particular case of COPD. So because you say that he is an young male, just about 45 years male, and has history for the past 8 years of cough with expectoration, isn't it? So that means he must be having, when he was started having these, he must be about 36, 35, 37-year-old, isn't it? So male patient, young patient. So how this is going to be any positive findings as far as your case of COPD is concerned?
So in the young patient, we presenting to us with COPD, we should suspect of alpha-1 antitrypsin, possibility of alpha-1 antitrypsin deficiencies.
More of emphysema associated, superimposed with probably chronic bronchitis, isn't it? So that is what you may have, because chronic bronchitis usually does not occur in less than 40 years age. Usually after 40, and majority of the times, usually these patients will be quite old, 50 or 60-year-old. So in younger patient, you may have to suspect an alpha-1 antitrypsin deficiency, and you may have to ask for an alpha-1 antitrypsin levels as well. So just to check whether the patient has a genetically decreased alpha-1 antitrypsin or even absent alpha-1 antitrypsin. So just to ask you, because you mentioned about alpha-1 antitrypsin, what is the role of alpha-1 antitrypsin in prevention of emphysema? Because alpha-1 antitrypsin mainly produces emphysema as far as COPD is concerned, not the chronic bronchitis. But if the patient also has other exposures or other factors which can also produce chronic bronchitis. So early onset of chronic bronchitis in an emphysematous patient, that is always there. So what is the role of alpha-1 antitrypsin, where it is actually synthesized in the body?
Synthesized in the liver, sir.
Yes, very good. It's synthesized in the liver. How does it help in preventing lung damage?
So in patients with alpha-1 antitrypsin deficiency, on exposure to noxious stimulus, mainly due to cigarette smoking, there's an increased activity of the proteolytic enzymes called elastase, sir. So which causes degradation of the alveolar sacs. So alpha-1 antitrypsin actually inhibits the enhanced action of elastases, sir.
Neutrophil elastase.
Neutrophilic elastase.
Because whenever there is inflammation, neutrophils get attracted there, and they release neutrophil elastase. And neutrophil elastase is the one which actually try to remove all the damaged lung tissue. It's trying to remove all the damaged lung tissue because of the inflammation. It also removes the healthy tissue if it is in excess. So whatever the excess quantity of neutrophil elastase will be neutralized by alpha-1 antitrypsin. So whenever there is alpha-1 antitrypsin deficiency is there, so naturally neutrophil elastase will not have any antagonist. So unopposed action of neutrophil elastase on the lung can produce more damage. So parenchymal damage. So parenchymal damage will produce emphysema. So that is the one. So any young patient with typical history of COPD, you should always suspect probability of alpha-1 antitrypsin deficiency. Okay. And the second thing is male gender. Again, male gender, is it more common, the COPD patient?
Yes, sir.
Why male gender more preponderance of COPD?
One majorly because of the smoking history, sir.
Yeah, mainly the exposure. Females are also, known to develop COPD, but what is the cause for females to develop COPD?
Biomass fuel
Biofuel.
exposure.
Biofuel, burning of biofuels. So that can produce, especially the smoke, continuous inhalation of smoke almost every day for most of the daytime. So they do develop COPD. So, but more common in males, of course. And another thing is about he's a driver by profession, probably not
Exposure to outdoor pollution also.
yeah, middle class or lower middle class patient. So anything as far as this economic or financial status is concerned and COPD. Yeah, definitely the poor financial status of patient definitely makes him vulnerable to develop COPD. Along with if he has other factors which can promote him to develop COPD, like history of smoking or exposure to any inflammatory particles in the environment. So that is why, because nutritional deficiency also can be one of the factors, because we don't know why smokers do develop, because what is the incidence of chronic smokers developing COPD? What is the percentage of incidence of COPD developing in chronic smokers?
So 60%.
It is only 40%. That means 60% still may not develop. So there could be other factors
Don't develop 40%.
involved as far as the development of COPD is concerned. One of the factors may be some nutritional deficiencies, some of the factors deficiency there in nutrition as far as their daily oral intake is concerned. So that can also induce them to develop COPD. So actually, one more thing I observed in your case history, of course, you have said about the pain abdomen. You could have straight away said there that what was the diagnosis of the patient and then why has been posted for what sort of a surgery has been posted. So you could have said that he was admitted with pain abdomen and then he was investigated and found to have calculus cholecystitis. So he has been posted for laparoscopic cholecystectomy. So there, after that, you should have started your the patient having a comorbid conditions. So that would have straightforward, isn't it? Because at the end you say that patient posted for laparoscopic cholecystectomy, but nowhere in your history you have not suggested that he has been diagnosed with calculus cholecystitis. So that is not very important for us, but you should have mentioned there. So that is one thing which your history you should have said. And another very important is after that, the comorbid conditions regarding the COPD you wanted to present. So you have started with breathlessness. So in a respiratory disease patients, breathlessness starts first or cough and expectoration will start first?
Cough and expectoration.
So what you should have started with, the patient gives history of cough with expectoration for the past 8 years.
Yes.
Then to present, after 2 years, he started developing breathlessness.
Yes.
So, your history will be so confusing that when you start telling about breathlessness, as an examiner, I'll feel that you are presenting a cardiac case. Isn't it? In cardiac case, breathlessness always starts first. And because of repeated respiratory infections, they may also have cough with expectoration. Okay. No, I just noticed that thing in your presentation, the history. So you always start with, whenever a respiratory case you are presenting in the exam, always start with cough with expectoration, which are the principal, the history regarding any respiratory disease.
Okay.
And afterwards, yes, breathlessness you will have to expand on. Okay.
Yes.
So
Yes.
that is one thing. And just before going with your further history, how do you define COPD?
So, COPD is a common preventable and treatable disease that is characterized by persistent respiratory symptoms associated with progressive limitation in airflow, which is fully not reversible, and an abnormal inflammatory response of the airway and the lung parenchyma for noxious gases and particles, particularly caused by cigarette smoking.
Yes, very good. So this definition of COPD, you will be asked, and in this, very important is, chronic, persistent, progressive airflow limitation. That you have to talk about. Chronic, persistent, progressive airflow. So airflow limitation is the principal, the factor in the development of or in the pathogenesis of pathophysiology of COPD. So because of the airflow limitation, all the problems for the patient will start, especially, even breathlessness or whatever it may be. And the other thing is why this airflow limitation of chronic, persistent, progressive airflow limitation is because of the abnormal inflammatory response to a noxious particle in the environment. And this noxious particle could be anything. It can be, patient having a chronic smoking, tobacco smoking, or it can be, industrial fumes. He may be getting exposed, or in, bigger cities, pollution that also can produce abnormal inflammatory responses, or it can be biofuels, burning of the biofuels. So all these can be the causes for production of abnormal inflammatory response. Because, this is again very important in your definition, because every one of us, whenever we are exposed to an irritant in the atmosphere, we are going to have some amount of inflammatory response. So it need not be an abnormal inflammatory response. So an abnormal inflammatory response is the one which is going to be the cause for the COPD. And if it is a chronic exposure to an abnormal, chronic exposure to a irritant in the. So that is very commonly asked. One of the definitions you will be asked. And another very important thing is the airflow limitation, which may be partially reversible or totally may be irreversible. That is another part of the definition. Why this is important, whether it is partially reversible or may not be reversible at all. What is the implication of this particular part of the definition?
It indicates the severity of the COPD, sir.
No, I said partially reversible also.
Asthma associated with
that is what you have to differentiate, because bronchial asthma is not a chronic obstructive pulmonary disease unless it is an ACOS, wherein asthma
complicated
and COPD overlapping syndrome. That is when the asthma becomes very chronic, when permanent changes occur in the airways, then also it can have a partially reversible airway disease. So otherwise, asthma is completely reversible airway disease, isn't it? Yes. Whatever the airflow limitation occurs, it is an acute attack. And afterwards, once it is treated with bronchodilators and all, it is completely get reversed. Afterwards, the patient will not have any airflow limitation. So the most important difference, because of that only in the definition, you have to talk about this partial airflow limitation or complete irreversibility of the airflow limitation. So partial reversibility or complete irreversibility of the airflow limitation. So these are few of the things which are very, very important as far as when you talk about the definition. Even in theory, this becomes very, very important. Okay. Now is what are the diseases grouped under COPD?
Emphysema and chronic bronchitis.
Yeah, emphysema, chronic bronchitis, and another one is an ACOS. Asthma, COPD, overlapping syndrome. So these three things are important as far as COPD is concerned. For example, if you have bronchiectasis, you have bronchial asthma and cystic fibrosis, all these are not COPDs. So you should be very careful when you're. And COPD is a broad diagnosis. It is not particular diagnosis as far as whatever the individual disease in the COPD, isn't it? So COPD is it's a group of diseases wherein you can have asthma, you can have chronic bronchitis. So when you are talking about at the end, you have to say whether it is chronic bronchitis or whether it is emphysema. So that becomes, or sometimes it may be overlapping also. Chronic bronchitis and emphysema can be overlapping. So what is actually when you have, brought out in this patient as chronic bronchitis features, isn't it? So how do you define chronic bronchitis?
Chronic bronchitis, it's a clinical definition, sir. The patient will uh, cough continuously for 3 months over 2 years, at least for 2 consecutive years.
So that is what is, chronic bronchitis. The patient should have cough with expectoration at least for 3 months in a year.
2 consecutive years.
Or 2 consecutive.
Other causes of cough has been ruled out.
It have to be like bronchiectasis and other causes of chronic cough with expectoration, you have to rule out. So at least 3 months in a year for 2 consecutive years. That you should have to bring it in your history, that you have brought out in the history, that this patient has this particular history is there. So once this history is there, finally you can always tell about chronic bronchitis itself. So usually you may be asked about, so what are the differences between chronic bronchitis and emphysema? Another common question you will be asked in the exam. Just tell a few of the differences between chronic bronchitis and emphysema. First of all, you said what is the problem with chronic bronchitis as far as their breathlessness is concerned? What is the problem of in emphysema as far as breathlessness is concerned? Why breathlessness in emphysema? Why breathlessness in case of chronic bronchitis?
So in chronic bronchitis, breathlessness follows cough, sir.
No, what is the cause for breathlessness in chronic
bronchitis? Is a narrowing of the airways, sir. Inflammation.
Isn't it? So airflow limitation is there. In both airflow limitation is there, and here airflow limitation is the cause for airflow limitation is what? What produces airflow limitation?
In chronic bronchitis, the bronchioles are affected, sir, proximal to the terminal bronchiole. So there will be dynamic hyperinflation, sir. The air will not.
No. What is happening in chronic the pathophysiology there? It is an abnormal inflammatory response, isn't it? Abnormal inflammation is occurring. Because of the abnormal inflammation, what is happening to the epithelium of the mucosa of the bronchi and bronchioles?
There is mucus gland gets
hyperplasia and hypertrophy of the mucus gland.
Isn't it? So that is what you have to talk about. Hyperplasia of the epithelium that is occurring of the bronchi and bronchioles, that is producing a narrowing of the bronchi and bronchioles, the lumen. Plus, the hyperplasia of many of these cells, especially the blood cells, which secretes a lot of secretions. And especially when they are exposed to irritants, there is more secretion. Plus, these patients, whenever there is an obstruction, they are more prone for infection. Infections again produces more secretions. So secretions plus hyperplasia will produce more narrowing of the airways, and narrowing of the airways will produce airflow limitation. Isn't it?
Yes.
And another thing you said that is the one. Whenever there is airflow limitation is there, what happens to the resistance for breathing?
Increases, sir.
So resistance for breathing. So once the resistance for breathing increases, what happens to the work of breathing?
Resistance increases, work of breathing also increases.
Work of breathing increases. So work of breathing increases means the patient has to use his axillary muscles of respiration. So naturally, the patient will develop breathlessness. So that is the basic, pathophysiology of chronic bronchitis. So that is the reason why they bring out a lot of secretions, and cough with expectoration is very common in them. Okay. In emphysema, what is the pathophysiology? You already said that alpha-1 antitrypsin deficiency is there. What happens to these in pathophysiology as far as emphysema is concerned?
In emphysema, the elastic recoil tendency of the lung is lost, sir.
Why? What is the cause for loss of elastic recoiling of the lung?
Because of the destruction of the alveolar membranes.
Yes, very good. So alveolar walls, there will be parenchymal destruction. Alveolar walls get destroyed. So, they join together, all the alveoli. And, the air spaces will enlarge. There is a permanent enlargement of the air spaces beyond the So that is the one which is producing emphysema. So because of this, there is a loss of elastic recoiling of the lung. Normally, during expiration, there should be elastic recoiling of the lung. So because of the elastic recoiling of the lung only, whatever the tidal volume which has been inspired will be pushed back as an expired tidal volume, isn't it? So elastic recoiling is not occurring. So that tidal volume, part of the tidal volume will remain in the lung. So that is the cause for, hyperinflation of the lung in case of emphysema. Whereas in case of, as you are talking about chronic bronchitis, because narrowing is there, and this narrowing is more during inspiration or expiration.
Expiration.
Yeah,
Expiration.
during expiration. During inspiration, because more negative pressure in the pleural space. So the transmural negative pressure is even transmitted to the air spaces in the lung. So they also expand. So naturally, less restriction of flow during inspiration. So inspired tidal volume can enter the air spaces. But during expiration, because the lung comes back to its original position, and also there is a narrowing of the air spaces, and especially the bronchi and bronchioles. Plus, there is an obstruction, so air cannot come out. So the inspired tidal volume and expired tidal volume, there will be difference. That there is retention of the tidal volume inside the alveoli is occurring, and this is not a single process. This is a continuous dynamic process. So that is why, in case of chronic bronchitis, they develop what is called as a dynamic hyperinflation. So this hyperinflation is occurring with every breath. Every breath, inspired tidal volume goes and expired tidal volume will be less. So some amount of air gets retained, isn't it? So that is what. Whereas in case of emphysema, what kind of hyperinflation is occurring?
Static.
Yeah, static. So this you should understand. So dynamic hyperinflation in case of chronic bronchitis and static hyperinflation in case of emphysema. But hyperinflation is occurring in both. So the lung will be very big. So lung will be very big means what happens to the FRC?
FRC increases.
Yeah, FRC increases. So in these patients, FRC increases. And FRC increases as a result of increase in residual volume or increase in expiratory reserve volume.
Increase in residual volume.
Yeah, because FRC is a combination of residual volume and expiratory reserve volume. So here actually expiratory reserve volume will not increase. Actually, it may decrease. But residual volume will increase. So increase in residual volume is the most common feature in all chronic obstructive pulmonary disease. And again, what happens to the total lung capacity?
Total lung capacity increases.
Total lung capacity also will increase in COPD. So that is a basic difference as far as emphysema and chronic bronchitis. But in both, there is going to be increase in total lung capacity and increase in residual volume. But the pathophysiology is different. Okay, what about the dyspnea in each? Who will be more dyspneic? Is it chronic bronchitic patient or emphysema patient?
Emphysematous patient will be more
emphysematous patient because of static hyperinflation. He will not be able to collapse the lung at all. So he will have more dyspnea. But who is called as a blue bloater? Who is called as a pink puffer?
Chronic bronchitis, we call it as blue bloater, sir. And emphysema, pink puffers.
Yeah, why do you call a chronic bronchitic patient as a blue bloater?
So because of the cyanosis, the patient is more prone for hypoxemia and cyanosis, sir. So,
because more narrowing of the airways, isn't it? More narrowing of the airways will produce more air travel, dynamic hyperinflation. And that can lead to actually more hypoxia. What is the cause for hypoxia in chronic bronchitic patients?
Sir, more CO2 will be retained in the alveoli, sir. So
yes, very good. More CO2 will be retained. Because why CO2 will be retained? Because these patients, finally, they'll go in for ventilatory failure, not hypoxemic failure, type 2 failure. Why ventilatory failure?
Because of in the alveolar gas equation, sir, the alveolar ventilation is equal to tidal volume minus dead space, sir. So these patients will have more dead space, and because of the carbon dioxide retention, they will not be able to compensate by increasing the tidal volume, sir, as lung is already inflated. So they will develop.
You should always be very clear in your answering. You know the answer, but you are not very clear in your answering. So see, one is you are talking about alveolar ventilation. That is correct. So alveolar ventilation is tidal volume minus dead space multiplied by respiratory rate, isn't it? So whenever tidal volume decreases, alveolar ventilation decreases. Whenever dead space increases, alveolar ventilation decreases. And whenever respiratory rate decreases, alveolar ventilation decreases. So any one of these can occur. But in these patients, why do they develop alveolar hypoventilation is because of the increase in dead space. So why increase in dead space in these patients? Because of air
Because of the increased airway pressure, increased alveolar pressure.
trapping. Because of the increase in air trapping. So once the air trapping occurs, so naturally the alveoli are hyperinflated. Hyperinflated alveoli will also have increased alveolar pressures. And once the alveolar pressures are increased, so naturally the arteriolar and the venous pressures of the pulmonary vessels will decrease. That is what we usually describe zones of lung, John Beaver's zones of lung, isn't it? So zone 1, 2, 3, and 4. So can you just tell what are these different zones of lung? What is zone 1?
Zone 1 to 4, sir. The zone 1, the alveolar pressure will be more than the arterial pressure, and the arterial pressure more than the venous pressure, sir. In zone 2, the arterial pressure will be more than the alveolar pressure, and the alveolar pressure will be more than the venous pressure, sir.
Yes,
in zone 3, we have the arterial pressure is more, arterial and venous pressure more than the alveolar pressure.
So there is one more zone 4 also is there,
Zone
where
4, but
interstitial pressure, where the arterial pressure is higher than the venous pressure, which is higher than the interstitial pressure, and which is higher than the alveolar pressure. So alveolar pressures will be least in zone 4 and zone 3, where collapse of these alveoli can occur in zone 3 and zone 4, where the closing capacity will be higher because of that. But in these patients, because zone 1 will increase. Zone 1 is where ventilation is higher than the perfusion. Isn't it? VQ will be more than 1. That we call it as zone 1. So because of the alveolar hyperinflation, so zone 1 will increase. So zone 1 increases means the dead space increases. Dead space is increasing and tidal volume is not increasing. That means the alveolar hypoventilation is occurring. And whenever we talk about ventilation, we always, relate ventilation to the carbon dioxide excretion from the body. So carbon dioxide excretion will decrease. So the PaCO2 levels will increase. These patients will develop hypercarbia, isn't it? So that is why they go for ventilatory failure, which is called as the hypercapnic hypoxemic respiratory failure. So whether it is emphysema or chronic bronchitis, they are more often. But among them, again, chronic bronchitis, because the narrowing is much higher of the airways in chronic bronchitic patients, so they go for early failure, respiratory failure. Once they are going in for early respiratory failure, because of hypercarbia and hypoxemia, they do develop increase in the pulmonary vascular resistance. So pulmonary hypertension that develops. Pulmonary hypertension will in turn produce right heart failure. So that means, that is why right heart failure means edema. They bloat, isn't it? They are hypoxemic and also they bloat. That means they have a lot of edema. That's why they are called as blue bloaters. And one more thing you may be asked is why they are hypoxemic. So they have, now you said that they have increase in carbon dioxide. Now you have to talk about alveolar air equation. So Ramanathan was talking about alveolar air equation. So what is this alveolar air equation and how do you relate that to the hypoxia in these patients?
Alveolar gas equation is PaO2 minus PCO2 divided by respiratory quotient, sir.
Very good. So otherwise, how do you get the PiO2 or?
Atmospheric pressure minus
water vapor pressure into FiO2.
Yeah, Pb minus PH2O multiplied by the FiO2 and minus the PaCO2 divided by respiratory quotient. What is respiratory quotient?
0.8.
What is it? How do you get that? 0.8 is okay, but what is respiratory quotient as such?
The ventilation perfusion average of all the 4 zones.
No, it's not the ventilation perfusion.
The eliminated CO2 by the amount consumed, intake.
So it is actually VCO2 divided by PO2. Or you can say that it is the ratio between the carbon dioxide expiration divided by the oxygen utilization, isn't it? Consumption or utilization. So that is 200 divided by 250 normally per minute. So that comes to 0.8. So PaCO2 divided by 0.8. So that is actually, if PaCO2 starts increasing, so your partial pressure of alveolar oxygen will start decreasing. Because as we said that the definition for calculating partial pressure of alveolar oxygen by alveolar air equation is that Pb minus PH2O multiplied by the FiO2. This is actually the PiO2. So once minus PaCO2 divided by respiratory quotient. So if PaCO2 is increasing, so naturally your partial pressure of alveolar oxygen will come down. And once the partial pressure of alveolar oxygen comes down, the partial pressure of arterial oxygen also comes down, isn't it? Though the AA gradient may not increase much here.
Yes, sir.
Why AA gradient does not increase here?
Because there is no, the gas exchange is not affected, sir.
Yeah, gas
The
exchange.
uptake of gas exchange is intact.
It is affected, but not affected much.
Yes.
It is not affected much. That is why, that's how you can differentiate between hypoxemic respiratory failure and hypercapnic respiratory failure. In hypoxemic respiratory failure, the partial pressure of alveolar oxygen will be normal. But there is a problem in gas exchange at the alveolar capillary membrane. So there will be a wide AA gradient. Alveolar to arterial partial pressure of oxygen gradient will be very high. So that is what in ABG you will have to look for. For example, if you look for in the ABG, if there is hypoxia, and then you look for the AA gradient. If the AA gradient is very high, it's an hypoxemic failure.
Yes.
If it is hypoxia with AA gradient normal, that means it is ventilated failure.
Yes.
These are some of the very important things you should always understand. Even in case of, especially in emphysema, there is more amount of parenchymal destruction also is there, tissue destruction. So alveolar capillary membrane is also destroyed. That is the one also which adds on to the hypoxia in these patients. So invariably, these patients will have hypoxic, hypercarbic type of ventilatory failure. So anyway, chronic bronchitis patients will go for early carpulmonale, whereas emphysematous patients, they are called as pink puffers. Why do you call them as pink puffers?
Because they, compared to chronic bronchitis patients, they do not have much hypoxia, sir. So there will be.
Why they do not have much hypoxia? Though they are, they have increase in dyspnea. Severity of the dyspnea is more in case of emphysematous patients when compared to COPD patients, chronic bronchitis patients. But still they are pink. They are pink puffers.
Yes, sir.
You should realize they don't have so much of narrowing of the airways.
Yes, sir.
Unlike their main problem is, destruction of the parenchymal alveolar walls. So static hypertension of the lung is the main problem. Second thing is they are young patients. Because we already discussed emphysema occurs in younger patients. Chronic bronchitis occurs in older patients. So because they are younger patients, they can increase their work of breathing in order to compensate for this loss of elastic recoil. So since they can increase the work of breathing, so their alveolar ventilation will not be so much compromised when compared to the compromisation of the alveolar ventilation in case of chronic bronchitis patients. That is why they can maintain their PaO2. Because they can maintain their PaO2, they are pink and they are increasing their work of breathing. That's why they are puffers, pink puffers. So now you know what is the difference between blue bloaters and pink puffers, isn't it? So this is another very important difference. Sometimes you may be asked in the exam regarding the two different categories of COPD to differentiate actually, because finally you will be telling either emphysema or chronic bronchitis, or you may say COPD, then you may be asked which are all the diseases under this particular heading, and then they may ask you about the differences. So that is one thing. And another thing is, the PaO2 will be much lower in which condition?
Chronic bronchitis.
Yeah, chronic bronchitis, PaO2 will be much lower because they are cyanotic, they are blue bloaters. That's already, and the pulmonary hypertension will be, much severe in which condition?
Chronic bronchitis.
Again, pulmonary hypertension will be much severe because they are more hypoxic, and that is why they do develop early carpulmonale also. What about the prognosis?
Prognosis is bad in
It is bad in
Bad in
chronic
chronic
bronchitis, sir. It is better in emphysema.
Yeah, okay. So that is another very important thing as far as the difference between chronic bronchitis and emphysema is concerned. And more common among them is what? Which particular disease is more common?
Bronchitis.
Yeah, chronic bronchitis is more common than emphysema. Emphysema, it's a genetical mediated disorder. It has to have the alpha-1 antitrypsin deficiency has to be there, and also it runs in families, isn't it? So that those things you'll have to know about. So coming to individual complaints in these patients regarding his respiratory disease. So you were talking about the patient's complaint of cough with expectoration, isn't it? And then in the definition also, we were discussing about chronic bronchitis. You have to rule out other causes of the similar complaints of persistent cough with expectoration. So how do you, based on this particular history, whatever he has, how do you differentiate the patient not to have bronchiectasis? Because management will be differing if it is chronic bronchitis and bronchiectasis. How do you differentiate chronic bronchitis with bronchiectasis? Both will have cough with expectoration, isn't it?
Bronchiectasis patients will have copious sputum production, sir. The quantity will be much increased, sir.
Okay,
and
much clearer. Okay.
Particular position, they will be able to produce more sputum, sir.
Yeah, because that is one of the most important thing which you have not asked in this. The position and his relationship with the sputum production, isn't it? So that is very important because in chronic bronchitis, it can affect in one side. Sometimes it can be bilateral, depending on whether the patient has got cystic fibrosis, again a genetically mediated disease, which is not so common compared to bronchiectasis. So in bronchiectasis alone, it can affect only on one side. So naturally, in the the secretion draining position, if he is lying down, gravity, so the patients will bring out more secretion. So this particular typical history you should bring out in the history when you are talking about cough with expectoration, because here you will have to rule out other causes of cough with expectoration to finally to come to a diagnosis of chronic bronchitis. Okay, so that is one thing. So positional relationship with his sputum production and cough. And again, this cough with expectoration, will it be there only for 2-3 months in bronchiectasis or it's present throughout the year?
Continuously throughout.
Yeah, it can be there throughout the year because, there is a persistent total dilatation of many of the larger airways has occurred. So there is accumulation of secretions. So secretions tend to get infected. So these patients will have copious sputum production and also can be there throughout the year. It need not be 2-3 months in a year, like chronic bronchitis. So this is another differentiating feature. And the third differentiating feature is when these patients with chronic bronchitis will bring out more sputum as far as the day and night is concerned.
So more in the night, days, sir.
Early morning.
Day means which part of the day? Chronic.
Early morning. Early morning.
More in the
Early morning, isn't it? It is called as a smoker's cough also, isn't it? So overnight, they may not be coughing much, so there'll be retention of secretion. So early morning, they start, coughing out and bringing out secretions. And afterwards, as the day progresses, the amount of secretions and cough may come down. Whereas such a diurnal variation is not there with bronchiectasis. So these are some of the differences you have to bring in the history to rule out bronchiectasis. And bronchiectasis can be due to a particular, maybe some infection that has occurred in the childhood, maybe a pneumonia infection that has occurred in the childhood, or it can be because of a genetic predisposition of cystic fibrosis. So that is why it is, especially the history will be very long history from the childhood, bronchiectasis, unlike chronic bronchitis, which is a late development, especially after 50 or 60 years. Understand? So these are some of the important things you'll have to bring out. And another very important thing is, the amount of sputum production. Again, why it's important for us as anesthesiologists.
So to know whether this wet lung or dry lung.
Yeah, when do you say a patient has got wet lung?
So more than 100 ml per day, sir.
More than 100 ml, because you have written as the cup, and that is what how you should present. 1 cup full is how much?
200 ml.
200 ml.
Yeah, 200 ml. So even if you say more than half a cup, that means the patient is bringing out more than 100 ml. So why it is again important to know whether the patient has got a dry cough or cough with expectoration of more than 100 ml per day?
Sir, suggestive of active infection.
For elective procedures, when the patient has wet lung, we try to optimize the patient before taking up the patient for general anesthesia.
Why should you optimize, or why should you bring the lung to a near dry condition?
So that we can prevent the reduce the post-op pulmonary complications.
Yeah, because already there is so much of secretions. The lung is a wet lung. So much of secretions means tend to get infected in the post-operative period, because ability to cough in the post-operative period may not be effective for these patients. So once it's not effective, so much secretions are already there, the patient will end up with severe post-operative pulmonary complications, and he can even die or have a prolonged hospitalization because of the post-operative pulmonary complications, isn't it? So emergency surgery, you don't have any other, you'll have to take up the patient. But as an elective procedure, you'll have to, bring the patient to a near dry state, so that you can reduce the incidence of post-operative pulmonary complications. So optimization of the patient is very important. So when do you say the patient has been optimized as far as his sputum production is concerned?
More than 8 weeks.
No. When do you say that he is
Less than 20 ml per day.
dry? Less than 20
ml
per day. That is hardly any sputum production. So that means the patient now has been brought to a dry lung state. So definitely his incidence of postoperative pulmonary complications will come down. So that is why you have to know in the history, you have to get this particular history of what is the amount of sputum production. Then is, whether diurnal variation and then variation as far as the position is concerned, those two you have not asked, and that is very important to rule out bronchiectasis.
Yes, sir.
Okay, sir.
Then the next thing is, the color of the sputum, sometimes you may have to talk about. So what are the different colors of the sputum and why it's important for us to know about?
Sir, white mucoid sputum indicates that no active infection, sir. Whereas a yellowish or a greenish sputum indicates bacterial infections.
Greenish is Pseudomonas.
Pseudomonas, yes, sir.
Yellowish is purulent. White is mucoid.
Yes, sir.
Okay.
And any pink sputum, and we have to think of pulmonary edema.
Pulmonary edema is,
Pink
frothy
sputum. Okay. Then black.
As per the process,
It can be
pneumoconiosis.
Pneumoconiosis or aspergillosis.
And current jelly we have, sir. Klebsiella.
Okay.
And rusty sputum in pneumococcal pneumonia.
Yeah, pneumococcal pneumonia. So,
and anchovy sauce like sputum in amoebic liver and amoebic lung disease.
Or even amoebic liver abscess, entering into the lung also can produce anchovy type of sputum. Very good. So this is again very important for us to treat the patient, isn't it? What kind of the medicines we'll have to give for the patient to see that his sputum production is reduced. And one more thing is blood in the sputum, again hemoptysis. So what are the causes for hemoptysis?
Lung carcinoma.
Pardon?
Lung cancer. Lung carcinoma.
Most common cause in India.
Tuberculosis.
Pulmonary tuberculosis. Pulmonary tuberculosis is the most common cause in India. Okay. Other causes, as you said, it can be a malignancy, pulmonary malignancy. Okay. Anything else? Pulmonary infarction. And sometimes in patients with chronic bronchitis also you can have, but it will not be so copious when compared to tuberculosis, and also in patients with malignancies of the lung. So hemoptysis is another thing which you may have to ask. So that is very important. And one more thing is, we were discussing about these patients you said that breathlessness, dyspnea, because cough, expectoration, that is sputum production, and dyspnea. These three are the very common complaints or features as far as chronic bronchitis, which is the most common COPD in India. So coming to the breathlessness, which is very common, so you should always present it as a third one. After cough, after expectoration, and then breathlessness.
Yes.
That's how they develop respiratory disease problem. Otherwise, we may think in terms of cardiac disease producing dyspnea. Now, what is how do you grade this dyspnea in these patients? That is again common thing you have graded. Just to ask you.
So there is a Roizen's classification and a modified medical council MMRC classification.
Okay.
So grade 0 is
which one you are talking about?
Roizen and MMRC, sir.
So first you tell about Roizen and then you can talk about MMRC.
So in Roizen we have 5 grades, sir, grading from 0 to 4.
Okay.
Grade 0, there is no limitation in patient experience, no limitation in pace and distance, sir. In grade 1,
first thing you should always start whenever you are talking about whether this Roizen's classification is patient walking on a level ground.
Level surface.
That is very important. So you start like patient walking on a level ground. Now grade 0 is no limitation for pace and distance. Okay, he can have a rapid pace also, and unlimited distance he can walk. So no limitation for pace and distance. Okay, grade 1.
Grade 1, there is limitation in pace but not in distance. The patient feels comfortable to walk as far as he walks in his own pace.
Yeah, but now he will be walking slowly.
Yes.
He may not be walking with the same pace. Okay, grade 1. Grade 2?
Grade 2, there is limitation of pace and distance. Okay. Patient tells he needs to stop in between to take it.
So what you call that block limitation?
Block limitation is 100 meters. Patient.
One block is roughly 110
meters. 100 to 110 meters.
110 meters is one block. So he's not even able to walk for one block. He'll become breathless. Okay. So grade 3?
Grade 3 is covering in small distance, like
minimal distance.
Minimal distance from bedroom to kitchen, like this.
Yeah, minimal. Grade 4?
Dyspnea on exertion.
At rest. So that is how Roizen's classification, which is given in Miller 7th edition, it is there. In all the editions in Miller up to 7th edition, and 8th edition also it is there, but 9th edition somehow it is not there. Anyway, but sometimes you may be asked, it is better to know, because Roizen had written about that particular chapter on concurrent diseases and anesthesia. That's how he had included this particular classification of breathlessness. It is very easy. Walking on a level ground, limitation of no limitation for pace and distance, limitation for pace, no limitation for distance. That is grade 1. So limitation for both the pace and distance, block limitation, minimal distance, and at rest. That is what Roizen's classification. Okay, what about modified medical research council questionnaire? It is questionnaire. Based on that questionnaire, you classify.
Yes, sir.
So MMRC, short form.
Yes, sir. So we asked the patient whether he has any breathlessness on walking uphill or walking at a fast pace, sir. If we
grade 0 is what? Grade 0 is,
there is no difficulty in breathing, even while walking uphill or at a fast pace. Sir.
No difficulty in breathing, no breathlessness.
Yes, sir. Okay,
grade 1 is?
There is my breathlessness on walking uphill or on walking at a fast pace, sir.
Yeah, hurried pace.
Hurried pace.
Okay. Then
grade 2 is on level ground. He's not able to keep up with this person of same age, sir.
That means pace has come down.
Yes, sir.
His walking pace has come down.
Yes, sir.
Just like Roizen's only. That is grade 2. Okay, grade 3.
Grade 3, less than 100 meters, a patient develops breathlessness and has to stop before continuing to walk.
Again, that block limitation is there, isn't it? Okay. Then grade 4
on minimal, on walking with inside home also, patient develops breathlessness, sir.
Yeah, minimal
activities.
Minimal distance. That is another very important thing. So you have to bring out this particular thing, because invariably you will be asked about how do you classify? Yes. And one more thing is, why do you want to classify? What is the importance, anesthetic importance as far as classification of grading of breathlessness is concerned?
So to know the severity of the dyspnea, sir.
Okay, why should you know about the severity of dyspnea as anesthesiologist? More severe the dyspnea means more severe.
More less the cardiopulmonary reserves.
No, more severe is the disease, isn't it? So more severe the disease, more problems as far as your anesthesia is concerned, especially the postoperative, intraoperative and postoperative pulmonary complications are concerned. So you have to bring the patient from probably a severe grade to a milder grade. That is what your preparation is, isn't it? So that is what unless you know what is the grade, how do you know that your preparation is effective? Isn't it? Then only you know that, okay, you have prepared for about 8 weeks this particular patient. Then once his dyspnea grading has come down, that means you know that it is effectively you have prepared the patient and his chances of postoperative pulmonary complications
are reduced.
Isn't it? So that is another very important thing. So one more, sometimes I have seen one of the examiner was asking about CAT scoring. What is this CAT scoring as far as COPD patients are concerned?
Risk CAT scoring.
CAT scoring in history only. It is COPD assessment test scoring. CAT means CAT, COPD assessment test scoring of these patients. So what are the factors that are involved and what usually you have to ask questions. Again, like MMRC, it's a questionnaire. CAT scoring is also a questionnaire. So what are usually 8 factors you'll be asking about regarding the patient's answers. The patient himself has to grade. It is from 0 to 5. So 1 is about his cough. 0 means hardly there is any cough. And 5 is the maximum amount of cough the patient has. 0 to 5. So 1 is cough. Second thing is, the sputum production. 0 is hardly no sputum production. 5 is the maximum amount of sputum production. Okay. So third thing is whether the patient has any tightness of the chest. Because, if he has more amount of narrowing of the airways, more tightness of the chest is there. So that also you have the patient will be scoring from 0 to 5. That is the third. Okay. Fourth thing is breathlessness. He only classifies the severity of his breathlessness. Again, 0 to 5, breathlessness. And the next thing is sleep disturbance. So how much is the sleep disturbance? So he'll score again 0 to 5 because many of these COPD patients will not be able to sleep well in the night time. And that adds on to the misery for these patients because whole night they may have cough, expectoration, and also they may have breathing difficulty. So sleep deprivation is another one. So then what about his management of day-to-day activities? So that is another thing. 0 to 5, he'll have to give the scoring. And the next is what about his confidence in venturing outside alone? So whether he thinks that, okay, I can go and manage my day-to-day activities everywhere I can go, or I require somebody's assistance. So that is again 0 to 5. Finally, the energy levels, what the patient think about energy levels. So usually it is 0 to 5. So this is what is called as CAT scoring. So this is given to the patient himself, the questionnaire. The patient will mark from 0 to 5, 1, 2, 3, 4, 5. So then finally you add all these things. So 1 is the severity of cough, severity of sputum production. 3rd is severity of the tightness of the chest. 4th is breathlessness. 5th is his day-to-day activity. And then 6th is confidence. 7th is sleep disturbances or sleep. And then 8th is energy levels. So based on whether it is less than 10 or more than 10. If it is total score is less than 10, you think that it is a mild disease. If it is more than 10, the patient's disease is severe. And usually you classify these COPD patients into ABCD based on MMRC grading, then CAT scoring, and also the acute exacerbations they have. you invariably they'll have acute exacerbations, isn't it? So you have acute exacerbation in the y-axis, and in the x-axis you have the MMRC grading and the CAT scoring. Okay, so you have, four. You can have, you can draw four chambers in that. So A, B, C, and D. You are following, isn't it?
Yes,
A,
sir.
B, C, and D. So A is where, the MMRC score is less than 2 and CAT scoring is less than 10. And his acute exacerbations almost not there, or probably 1 or 2 acute exacerbation in a year, not requiring hospitalization. That is grade A. Grade B is, CAT scoring is more than 10, MMRC score is more than 2. But acute exacerbations are not many. Same thing, because it is in the y-axis. So again, grade C. Grade C means exacerbations are high. Number of exacerbations requiring hospitalization are increased, but still, MMRC score is less, and also his CAT score is less. And D is the very severe one, wherein CAT scoring is high, MMRC scoring is very high, and his acute exacerbations requiring hospitalization is also very high. So why this is important to know? ABCD. Why should you classify these patients into ABCD as far as COPD patients are concerned? For management purposes. Yeah, because GOLD, you must have seen the global initiative for management, isn't it? That GOLD, that is the one which is the gold standard for management of these patients. So global initiative for management of obstructive liver disorder patients. So they classify these patients into ABCD based on acute exacerbations and also based on MMRC and CAT scoring. So that is why it becomes important for us also. We know that if a patient is in C or D, we know that the patient requires a more longer number of days duration. That means the disease is quite severe in these patients. So that is why this CAT scoring also will become important. So I still remember when I had gone as a DNB examiner, one of the examiners was fond of asking about CAT scoring in COPD. So suppose one examiner may come, or they may be asking about CAT scoring for you also. It is better to know about CAT scoring. Okay, so that is one additional thing which you should always know about in the history when you are taking. So another very important history is regarding the acute exacerbations. What do you mean by an acute exacerbation?
Sudden worsening of a symptom which needs treatment by either oral medications or hospital admissions.
Yeah, increased severity of the symptoms requiring additional therapy.
Yes, sir.
That is the definition of acute exacerbation. Increased, severity of the symptoms requiring additional therapy for management. Okay.
Yes, sir.
So how do you grade these severity of acute exacerbations? What is mild, what is moderate, what is severe, what is very severe?
Mild, the patient does not need hospital admission, sir. Can be managed at home. Moderate, the patient requires hospital admission, but not ICU admission, sir.
Very
severe, the patient requires ICU admission and non-invasive ventilation, sir.
Can be managed.
Yes.
With NIV. Okay.
NIV. Very severe is patient needs mechanical ventilation, sir.
Okay. So that is one thing we have to know what kind of an acute exacerbation this patient was having. So that is what in that scoring of or classifying these patients into ABCD also that helps, because C and D patients will have these kind of severe acute exacerbations, and number of acute exacerbations also is very important. Suppose if they are having frequent acute exacerbation, why should you ask about that particular history of frequent acute exacerbations? Why it's important for us to know about?
So the patient having a frequent exacerbation will have a frequent hospital administration also.
No, frequent acute exacerbation, for example, in a year, he is having more than 5, more than 6. Many times.
He needs additional therapy, sir. The disease is not controlled with this regular
No, it shows that these patients are highly likely to develop postoperative pulmonary complications. Any patients with repeated acute exacerbation is having more severe disease, and definitely he is likely to develop postoperative pulmonary complications and require more days to optimize the patient. So that is one thing about that. And another very important thing is, you see, you have taken the history, but you have not written when was the last acute exacerbation. You have just written he has 2-3 acute exacerbation in a year, but you have not written when was the last acute exacerbation. Why it's important to know when is the latest acute exacerbation?
When the latest acute exacerbation is less than 1 month, then we have to take more time to optimize the patient for elective.
So that patient you should not take up immediately.
Yes.
If the patient has had an acute severe exacerbation within this month, and if he is posted for any kind of non-thoracic or thoracic surgery, it is better to postpone. Because this is the patient who is likely to develop a high incidence of postoperative pulmonary complications. Because, finally it comes to the PPC, postoperative pulmonary complications, how to prevent in these respiratory disease patients. So if he has, acute exacerbation has occurred within this month, better to, postpone, take our own time to optimize, and then only take up. That is why that recent history of acute exacerbation, you have to bring out in your history. That you have not brought out because you just said that he gives history of 2-3 acute exacerbations. When was the last one? That is another thing. And one more thing is, suppose if the patient gives history of very severe acute exacerbation wherein he required invasive mechanical ventilation. Again, why that particular history is important?
So because after if the patient had a invasive ventilation in the previous admission, we need to know about the tracheal patency. So there will be more chances of tracheal narrowing in that. So it leads to difficult intubation and intra complications can happen, and also post-operative pulmonary complications.
Yeah, that is very good. So you have to ask the patient if he gives history of very severe acute exacerbation which required an invasive mechanical ventilation with an endotracheal tube, how long it was. That becomes very important. How long the patient was on mechanical ventilation, because the longer the days, more chances of post-extubation narrowing, isn't it? So if the patient gives that history, it is better to take an X-ray of the neck and AP view to know whether there is narrowing of the airway, so that you can go for a smaller endotracheal tube. So that is another history which is very important, which is lacking in your presentation. So why I'm telling you is these are the things which you can include when you present a case history in your final exams. Okay, very important, certain things. And one more thing is, another important thing is, that these patients are prone for chronic carpulmonale, isn't it? So there are two things, acute carpulmonale and chronic carpulmonale. What is acute carpulmonale?
Sudden increase in pulmonary vascular resistance causing right heart failure.
Can you give an example?
During intubation, if we fail to prevent
intubation may not produce so much. Producing acute acute increase in
pulmonary embolism, massive pulmonary embolism.
Yes. Pulmonary embolism, it produces acute carpulmonale. Whereas in these COPD patients, they don't develop acute carpulmonale, they develop chronic. What is carpulmonale as such?
The lung disease causing failure of the right heart.
Yeah, primary lung disease producing secondary right ventricular failure. That is what is chronic carpulmonale. So how do you know that this patient has not developed chronic carpulmonale?
History of edema, pedal edema or abdominal distension.
Yeah, because it's the right heart. So right heart failure. So usually the patients will have raised JVP, tender hepatomegaly, and pedal edema, because your patient also has right upper pain, isn't it? So if he also has pedal edema, then you may have thought about patient developing chronic carpulmonale. And again, Ramanathan, why should you know about chronic carpulmonary? Whether he has or he doesn't have.
If there is
What does it show?
there is severe pulmonary hypertension, sir, which
Very
has
good.
led to the carpulmonary. Then
Yes.
intraoperative, we have to prevent the factors that worsens the pulmonary hypertension, like hypoxia, hypercarbia, hypothermia, and acidosis.
Yes, very good. So one thing you know that he has severe pulmonary hypertension. Okay. Second thing is his right heart has tried to compensate, but it has failed now. Isn't it? That is why he has developed all features of right heart failure. Suppose the patient has features of right heart failure, can I take him up for surgery?
No.
Isn't it? Uncompensated cardiac failure patients should never be taken up for
Surgery.
kind of elective surgery. It's an acute cardiac condition. It is an active acute cardiac condition. Any active cardiac condition, no patient should be taken up for elective procedures. So it has to be treated. So that is the reason why you have to bring out in your history whether there is any symptoms of chronic carpulmonary. Okay, so one more thing. And another thing is, history of smoking is very, very important. And the smoking is the one which has produced chronic bronchitis in these patients. And it's one of the most common association and a risk factor for chronic bronchitis. And so try to bring that in the history of presenting illness only. Don't try to keep it in personal history of smoking, because this is the one which has produced all the problems of cough expectoration, breathlessness, and all those things. Okay, so always tell that when you are presenting in the history, when you are presenting, let it be in the history of presenting illness. That's what I told in the last this thing also. So causative factor should be brought in history of presenting illness plus medication history. These two should be in the history of presenting illness, so part of history of presenting illness. Now we have discussed about smoking, which is very, very important. So you have brought out the pack years, which is very important. You'll have to bring out. So what is a pack year? You brought out, just I'm trying to ask you again for
the number of
benefit of other people who are listening.
pack years is the number of packs the person has smoked for the duration of the year. So for how long have been smoking pack of cigarettes? Where one pack is 20
per day.
20 cigarettes per day.
Per day.
More than 40 is
multiplied by number of years. Isn't it? Or or otherwise number of cigarettes per day divided by 20 into number of years. Yes. Because each pack is how many cigarettes?
20 cigarettes.
20 cigarettes. That's why sometimes you may not get the number of packs by the patient history. You may say, I smoke 15 cigarettes a day or 16 cigarettes a day. Now you have to convert that into pack years, isn't it? So divided by 20, multiplied by number of years of smoking, you get the number of pack years. So when do you say it's significant pack years to produce COPD?
More than 30, sir.
More than 20.
20.
Anything more than 20 pack years is supposed to be significant enough as far as the history is concerned to be a causative factor for the development of chronic bronchitis. So that is one thing. Another one, again, you brought out is the smoking index. What is the smoking index?
Smoking index is number of cigarettes per day, sir, into number of years of smoking, sir.
Smoking. Okay.
That
it is not pack years. It is just number of cigarettes or BDs, whatever it may be. It need not be only cigarettes. It can be number of BDs also. And, BDs pack means it is different. It is not 20. What is usually we calculate as far as BDs? Again, in an exam question. When you say BDs, suppose the patient says that he's smoking BDs, not cigarettes. Then do you divide it by 20 or something else?
30, sir. 30.
25. We call it as cut. We don't say pack years, you can say cut years for BDs, isn't it? So BDs usually they say cut means, it's tied. It's tied. I don't know in Tamil, cut means, is it same thing? In Kannada, we call it
same
tied.
It means
same.
bundle on.
That is why they're called as one cut. One cut means 25 BDs. So that is why, you can even tell if the patient is smoking BDs, instead of telling pack years, you say cut ears, isn't it? So let the examiner ask you. So you have created a question there, and definitely he'll give you more marks probably because of the intensity with which you have taken the history. So that is and which produces more problems? Is it BDs or is it cigarettes?
BDs.
BDs, because they do not have filters.
Filters.
Plus, the leaf also will be burned. That is also inhaled. So the amount of carbon monoxide produced with BDs is much higher when compared to the cigarette. So this is one thing again you'll have to talk about. Okay. When you talk about smoking index, how do you classify the smokers based on the smoking index? Mild, moderate, and severe.
Moderate, severe. Yes.
Mild
Mild less than 100 100, sir. Smoking index less than 100. Mild
smoking
smokers.
index. Okay.
100 to 300.
100 to 300, more than 300.
More than 300.
That's how, mild, moderate, and severe, smoking index acts as far as the significance is concerned. Mild to moderate may not be so significant, but if the patient has smoking index of more than 300, it's quite severe enough to produce problems as far as the postoperative pulmonary complications are concerned. So now coming to, once you talk about smoking, so invariably you will be asked about all the problems associated with smoking. That is one very common question that is asked in the exam, and even sometimes smoking and anesthesia is a common short notes, 10-mark short. So can you just talk about what are all the problems associated with smoking?
Smoking, cardiovascular symptom effects, sir.
Start with always acute problems of smoking. Then you go for chronic problems or delayed effects.
Acute effects. Yes, sir. Acute, due to the nicotine present in the smoke, patients will have sympathetic stimulation, sir. Tachycardia.
No. One thing you should always realize, acute means it is because of carbon monoxide. You should talk about carbon monoxide problems because of smoking and carboxyhemoglobin. It is the respiratory problems are more common than the cardiovascular. First, you talk about all the respiratory problems as far as smoking and anesthesia is concerned. So because, more carbon monoxide the patient is inhaling. So this carbon monoxide will combine with hemoglobin, isn't it?
Yes.
And ODC
hemoglobin more than oxygen can combine with
carbon monoxide.
What is the affinity of carbon monoxide to hemoglobin compared with oxygen?
200 times.
300 times more 200. Affinity for combining with hemoglobin. So it can easily combine with hemoglobin, and it can even displace oxygen, isn't it?
Yes,
so
sir.
That is how it produces what is called as carboxyhemoglobin.
Yes, sir.
COHB, that is the abbreviation. CO, carboxyhemoglobin, COHB. So what is this carboxyhemoglobin? How you are concerned about the carboxyhemoglobin quantity in the blood?
Normally, carboxyhemoglobin in normal individuals is less than 1%, sir. Whereas in smokers, it can increase up to 10%, sir.
Not up to, it can be about 10%.
It can increase about 10%. Sir.
Yeah. So what is this?
The functional hemoglobin levels come down, sir. If it is 10%, then
functional hemoglobin levels have come down. Oxygen carrying capacity has come down, isn't it?
Yes.
So it can produce hypoxia or hypoxemia. Yes. So what kind of hypoxia it can produce?
Hypoxia.
No, there are 5 types of hypoxia, isn't it? Hypoxic hypoxia, anemic hypoxia, histotoxic hypoxia, stagnant hypoxia, P50 hypoxia. Yes. So these are 5. The hypoxia are usually classified as these 5 types. In that, you may be asked in the exam what kind of hypoxia this can produce. You said functional hemoglobin levels have come down. So
anemic hypoxia.
Anemic hypoxia. Isn't it? When functional hemoglobin levels have come down, it can produce anemic hypoxia. It can also produce P50 hypoxia. Why it can produce P50 hypoxia?
It shifts the oxygen hemoglobin curve to the left, sir. So it increases the binding of oxygen to the hemoglobin and reduces offloading of oxygen, sir.
So that is what any P50, if it is shifted to the left, or if P50 decreases, you call it as P50 hypoxemia. So carboxyhemoglobin or carbon monoxide can produce two types of hypoxemia. One is it can produce anemic hypoxia. Another thing is it can produce P50 hypoxia. Usually they will be asking you because you are concerned with carboxyhemoglobin, isn't it? Because it can produce hypoxia. And the next question is what kind of hypoxia? It is not going to produce hypoxic hypoxia or stagnant hypoxia or histotoxic hypoxia. So anemic and also the P50 hypoxia. Okay, it shifts the OD curve also to the left. Okay, what else? Any problem as far as your pulse oximetry monitoring is concerned?
It shows a false high value, sir.
False high value. Why false high value?
Because in our regular pulse oximeters, only two wavelengths are picked, sir.
Okay.
One is 660, 940 nanometers, sir.
660 is red or infrared?
660 is red, sir.
Red.
940 is infrared.
940 is. So we have only two dimensional or wavelength pulse oximetry, routinely what we use. Okay, so it absorbs. How do you differentiate oxyhemoglobin and carboxyhemoglobin? Because you said that pulse oximeter cannot differentiate. Why it cannot differentiate?
Because it's observed at the same wavelength of 940 nanometers, sir. So we need to go for
same wavelength of which 660 or 940?
940.
No, 660. It absorbs the same. You just see in the Miller pulse oximetry, you open that chapter. He has given that graph. So you can easily see both oxyhemoglobin and carboxyhemoglobin, they absorb the same amount of 660 nanometer, the red. But whereas infrared, what about carboxyhemoglobin? 940 nanometer wavelength. It doesn't absorb at all. Zero absorption of 940 by carboxyhemoglobin, whereas oxyhemoglobin absorbs a lot of, isn't it? Oxyhemoglobin.
Yes,
so, but because at 660 nanometer, it cannot, the pulse oximeter cannot differentiate between oxyhemoglobin and carboxyhemoglobin. That is why it thinks that carboxyhemoglobin is also oxyhemoglobin. That is why, though actual oxyhemoglobin saturation may be much less, so it gives you a spuriously high reading, isn't it? So that is another very important. So many times you must have seen a chronic smoker and you put the pulse oximeter there, it may be showing 100%, and you take that pulse oximeter probe and then put the same thing on your finger. Now it will be showing 97%. You will be surprised. Why 97? I am not a smoker. My lungs are perfectly all right, and his is it's showing 100%. So you cannot rely on the pulse oximeter reading. So what you require actually in such situations?
Coaximeter.
What is coaximeter?
Multiple wavelengths are used.
Yeah, multi-wavelength pulse oximeter is called as a coaximeter, so that it can definitely differentiate carboxyhemoglobin, methemoglobin, oxyhemoglobin, and deoxyhemoglobin separately. So that's how you know exactly what is the amount of oxyhemoglobin saturation and how much is the carboxyhemoglobin separately, isn't it? So what is the half-life of this carboxyhemoglobin in blood? For example, now the patient is not exposed to carbon monoxide. How long it can be there?
4 to 6 hours.
Yeah, 4 to 6 hours. And why do you know about this particular thing?
So that at least
cessation for taking up for elective cases.
Yeah, at least for about 24 hours if you stop him from smoking or abstain him from smoking. So this problem of carboxyhemoglobin will not be there. Can you hasten this process of decreasing carboxyhemoglobin in the blood?
Administering methylene blue.
No, not for carboxyhemoglobin. So what you can do is you can ask the patient to do some moderate exercise. He has to hyperventilate. So if he ventilates more, carbon monoxide also is removed. So you can bring down the half-life of carbon monoxide as well as carboxyhemoglobin to 4 hours. Suppose if you give 100% oxygen, Now there is a competitive antagonism, isn't it, between oxygen and carboxyhemoglobin, carbon monoxide for the same site of hemoglobin. If you give 100% oxygen, you can reduce the life of the carbon monoxide in the body by, it can reduce to 1 hour. So you can remove all the carbon monoxide from the body by just in 1 hour. If you give hyperbaric oxygen, you can reduce the carbon monoxide levels to near zero in 20 minutes. That is one of the applications of hyperbaric oxygen in carbon monoxide poisonings. Okay, this is the one acute problem as far as the smoking and the problems associated carboxyhemoglobin. So what is the other important effect of smoking on mucociliary transport mechanism, which is very, very important?
The mucociliary function is impaired, sir.
Yes.
So there is a hypertension, hypertrophy of the mucus gland. So there is increased mucus production and decreased clearance, sir. So there will be a lot of mucus stasis will be there.
So because of this, what is the problem?
The patient will be
more chance of
infection rates will be high.
Oh, you just say more chances of patient developing postoperative pulmonary
complications.
Yes. Now, everything for us is when these patients are posted for surgery. And what happens to them? Suppose if the patient is a chronic smoker and he has not abstained from smoking, you have stopped him from smoking only for a day. But what has happened to his his mucociliary transport mechanism is inhibited. He is bringing out a lot of more secretions. Secretions are not getting cleared because, ciliary activity is very important for clearance of the secretions. Each of the cilia beats almost 200 times a minute. And that's how, it brings the deeper level of secretions to the upper level of the respiratory tract so that the patient can cough and bring out these secretions. So if these ciliary activity is inhibited by smoking, so the secretions can get retained there. And again, wet lung and postoperative pulmonary complications chances are very high. So that is another reason why these patients are highly prone for PPC, or postoperative pulmonary complications.
Yes.
So how many weeks it takes for regaining the ciliary functioning?
4 to 8 weeks. 4 to 8
Yeah,
weeks.
4 to 8 weeks or 6 to 8 weeks you can also. So why it is important to know about 6 to 8 weeks it takes?
So that the mucociliary function is restored, sir. Once the patient abstains for 8 weeks.
So you have to stop the patient from smoking for at least
2 months.
8 weeks. 8 weeks. So that is another very important thing because sometimes you may be asked by the surgeons or by the patient himself, how long I should stop smoking before I posted for surgery. So ideal would be at least about 8 weeks. Okay. So that is another problem as far as his respiratory system is concerned. What more problems as far as respiratory system is concerned and smoking?
The airway will be hyperreactive, sir.
Very good. So the airway becomes hyperreactive because of the smoking. So why it's important for us to know whether airway has become hyperreactive?
Because of more chances of intraoperative bronchospasms can be.
Correct. So perioperative bronchospasm chances will be very high, and that can even lead to mortality. Perioperative bronchospasm is very, very dangerous complication. So you have to prevent. So these patients, because of smoking, they may have hyperreactive airways. So that itself is a problem. Okay, so that is another very important thing as far as his smoking history and pulmonary problems are concerned. What else as far as the pulmonary problem? One more thing is there.
Secretions.
Already you told about secretions. What about, you said that infections incidence of infections. Why these patients are prone for increased incidence of
delayed wound healing?
No, increased incidence of infection for his chest, lungs. Immunity, suppression of the immunity. And that can even produce delayed wound healing also, as you said. So suppression of the immunity directly by smoking is another very important aspect. Okay, now let us discuss about cardiovascular manifestations and smoking. What are the problems associated with CVS?
So patient will have tachycardia, sir.
Okay. Now, before that, what is he prone for because of smoking?
Ischemic heart disease.
That is what you have to talk about, isn't it? Ischemic heart disease, because these patients are highly prone for peripheral arterial diseases. Very common. You must have heard about Burgess disease, what is that? Angiitis obliterans. Thromboangiitis obliterans is Burgess disease, which was very common in older. I don't know whether it is still there nowadays. Also, you are getting, because we are not exposed to majority of these patients. Usually, many of these chronic BD smokers used to come for amputations because of peripheral arterial disease. So, arterial disease means even coronary artery also get involved. Even carotid arteries get involved. So once the coronary arteries get involved, that means atherosclerosis is hastened in these patients. Narrowed coronary artery. So naturally, these patients also can have early coronary artery disease, isn't it? So that also you have to evaluate these patients. If they are gives history of chronic smoking, then even in history also you may have to take history of coronary artery disease. It is usually associated with chronic smoking. So history of chest pain and even myocardial ischemia, myocardial infarctions. Patients may be on even multiple drugs for coronary artery disease. So because you are looking at the patient as a whole, you are not looking at the patient as having only COPD and anesthesia, isn't it? So the patient also may have coronary artery disease. So that also becomes important. And in this patient also has hypertension.
Yes, sir. Yes.
Hypertension can be because of increased sympathetic activity and also because of increase in the narrowing of the peripheral arterioles, and that has produced increase in systemic vascular resistance. That may be the cause for hypertension. Smoking, isn't it? So that is how the patient may be prone for ischemic heart disease. So you may have to even evaluate him for ischemic heart disease before taking up for surgery. So that is one thing. Again, you are talking about increased sympathetic activity. So why it's important again? There can be increase in heart rate. There can be increase in myocardial contractility because of
It increases the oxygen demand of the patient, of the myocardium.
demand supply imbalance.
Balance.
Always supply is decreased because of two things. One is narrowing of the coronaries. Second thing is, the heart rate.
Myocardial O2 demands.
Isn't it? So that is decrease the supply, and O2 demand is increase myocardial contractility and also increase in
heart rate itself can increase the demand.
So oxygen supply demand imbalance can occur, and these patients can have ischemia frequently. So that history you have to bring out. So these are in general about the smoking and anesthesia. So very important to rule out these effects of smoking when the patient gives you chronic history of smoking. Okay, so the next thing is medication history. So that should always come in in your history of presenting illness. What are the current medications the patient is having? So it can be bronchodilators. It can be even antibiotics. It can be drugs for carpulmonale, or it can be drugs for ischemic heart disease, or it can be drugs for hypertension, isn't it? So all these drugs you have to talk about. So one very important thing is they may have partial reversal of the bronchial narrowing, isn't it? That's what we discussed in. So they may respond to bronchodilators, and many of these patients can be on bronchodilator therapy. So how do you classify these bronchodilators?
Short acting
and long acting.
That is there, but first of all, you usually classify them. Just a minute. Hello. ನಾನು ಸ್ವಲ್ಪ busy ಇದ್ದೀನಿ. I'll talk to you after some. Okay, so one thing we're discussing about the classification. So you always classify them as based on what is their the structure or how do they act. So beta 2 agonists.
Short acting beta 2 agonist and long acting.
Afterwards, subclassification is short acting or long acting or something like that. So you always, when you are asked in the exam, you say beta-2 agonists,
Beta agonist,
xanthines,
corticosteroids.
Inhaled corticosteroids.
okay, and corticosteroids is okay.
Inhaled anticholinergics like ipratropium.
Mast cell inhibitors and also anticholinergics. So actually in them, beta-2 agonists, xanthines and anticholinergics are bronchodilators. Mast cell inhibitors, they are not bronchodilators, but they may help more in allergic problems, especially in bronchial asthma or asthma and COPD overlapping syndrome. That is more often used. And again, steroids, indirectly, they help by anti-inflammatory, reducing the mucosal edema and decreasing the secretions. So they help in the bronchial and dilatation of the bronchi and bronchioles, isn't it? So indirectly they help. Okay, now beta-2 agonists, coming to beta-2 agonists. So how do beta-2 agonists act?
So the beta-2 agonists, they act on the beta-2 receptors in the bronchial smooth muscle, sir, where there is a stimulus, it stimulates the adenyl cyclase for production of cyclic AMP.
Adenyl cyclase.
For cyclic, it stimulates the formation of cyclic AMP, sir.
No, what does adenyl cyclase do? What does it do? Beta-2 agonists combine with beta receptors, and beta receptors will produce, combination of beta agonist to beta receptors will stimulate adenyl cyclase. What does adenyl cyclase will do?
It converts ATP to cyclic AMP.
Very good. So converts ATP to cyclic AMP,
which in turn converts the protein kinase from its inactive form to active form, which causes bronchodilation.
Yes, very good. So that's how it is going to act, isn't it? By stimulating adenyl cyclase. So that is what beta-2 agonists. So how do you classify beta-2 agonists?
Short acting and long acting.
Short acting, long acting, and ultra long acting.
Ultra long.
So can you give some examples for short acting?
Albuterol, sir. Levoalbuterol.
No, salbutamol or terbutaline. Isn't it? They are short acting. So long acting? Solmetrol, formoterol. These are long acting. And ultra long acting? Indacaterol. It acts almost 36 to 48 hours.
48 hours.
Yeah, whereas the other long acting, they act for 24 hours. Short acting about 8 hours. So that is another very important thing we should know. Suppose this patient, if he is on beta-2 agonist, so what is the implications for us?
Hypokalemia.
Beta-2 agonists, why do they produce hypokalemia?
So because it causes the inward shift of potassium. Intracellular shift. Extracellular to intracellular shift of potassium.
Yeah, extracellular to intracellular shifting will occur. Why it shifts? All adrenergic drugs, you just think all adrenergic drugs, glucose, insulin, all these factors can push the extracellular potassium into the intracellular compartment. So there can be chronic hypokalemia can be there in these patients because of chronic inhalation of beta-2 agonists. These patients can have chronic hypokalemia. So if they have chronic hypokalemia, what is the implication? One is, should you do the investigations for these patients?
So you have to do electrolytes.
Yeah, serum electrolytes is very important to rule out any hypokalemia as well. Okay, then what is the effect of hypokalemia on your anesthesia?
Patient might be go for heart block.
No, not heart block. Dysrhythmias. Hypokalemia can increase the re-entry phenomenon or hyperpolarization of the action potential it will do. So it can produce a lot of dysrhythmias. That is one problem. Okay, what about the other problems? Hypokalemia. What is the effect of hypokalemia on neuromuscular blocking agents? Effect.
Prolong the.
Yeah, because potassium is very important for depolarization of the neuromuscular junction. So any decreased potassium levels the duration of action of especially non-depolarizing muscle relaxants can get prolonged. So that is why it is very important. And third thing is, if you give these beta-2 agonists, systemically, like parenterally or orally, they may themselves can produce dysrhythmias by directly stimulating the heart, because they're adrenergic drugs. Beta-2 agonists, though they are beta-2, they may not be selective in higher doses. They can also produce beta-1 agonism, because they may become non-selective once they are given in higher doses. Because systemically, you may have to give them in higher doses, isn't it? Because what is the dose, for example, of salbutamol? What is the dose you give through the inhalation route? How much? Each puff, meter dose. They're called as MDI, meter dose inhalation. One puff of salbutamol is how many micrograms? It is 100 micrograms. One puff. Suppose I want to give orally or systemically, how much I have to give salbutamol? I have to give 2 to 4 milligrams. Where is 100 micrograms? Where is 2 to 4 milligrams? It may be 20 to 40 times higher dose. When you're giving 20 to 40, because when you are giving systemically these drugs, they have to get into the blood, and then they'll be distributed to many of the tissues. Whereas when they are taken through the inhalation route, where the target,
action is
there is a lung and then bronchi and bronchioles. So it will be targeted to act on these, isn't it? So the required dose will be very low. So that's why when you give them in systemic route, so you have to give 20 to 40 times more. They lose their selectivity because of the beta-1 effect. They may produce dysrhythmias directly. Even they can produce tachycardia, they can produce palpitations for this patient, they can produce tremors. All these are side effects of beta-2 when they are given systemically. That is the reason while we always go for either inhalational route, meter dose, or nebulization, isn't it? So that is going to help. Okay, coming to the other group, that is the xanthines. So what about xanthines? Can you give some examples for xanthines?
Aminophylline.
What is aminophylline?
Theophylline, combination of theophylline.
It is ethylene diamine. Aminophylline is ethylene diamine. Usually it will be kept for you in the afternoon drug section. It will be there, and you may be given that aminophylline ampule, and then you may have to ask to talk about it. So it is ethylene diamine. It is a xanthine derivative. Another common drug which is xanthine derivative, trade name we use is derifylline, isn't it? Derifylline. So what is derifylline?
It's a combination of ethiophyllin and theophylline.
Yeah, it is a combination of ethophylline and theophylline. How much ethophylline, how much theophylline?
Ethiophyllin 25, sir. Thiophyllin 80 mg.
Yeah, very good. So ethophylline is 25 milligrams, and theophylline is 85 milligrams. Very good. So this I never thought that you will answer, but this also you get very high marks if you answer even such questions. Because again, derifylline ampule will be there in your afternoon, drug section. So you should be knowing how much each ampule contains. And again, how do these xanthines act?
They are PD inhibitors, phosphodiesterase inhibitors.
Very good.
So once that cyclic AMP that has been formed from ATP, it will be degraded by PD phosphodiesterase. So these xanthine act inhibits those phosphodiesterase, so that there is unopposed increase in cyclic AMP. So there is bronchodilatory effect.
So there is more amount of cyclic 3,5-AMP availability. So that it can continue to produce bronchodilation, isn't it? So one effect is phosphodiesterase enzyme inhibition. There are multiple effects of xanthines. What are the other effects of xanthines? How do they produce benefit for these patients with bronchoconstriction or respiratory disease? What is their central effect?
So it's a central CNS stimulant, sir.
CNS stimulant, respiratory center stimulation.
Respiratory center stimulation.
So that also will help
increase work,
breathing. by these patients. Directly, they produce CNS stimulation and respiratory center stimulation. That is very important. Okay, what about its effect on the diaphragm? It also stimulates diaphragm to contract. That is another very important, effect of xanthines on respiratory system. So that, the patients can, even peripherally, they can help in better breathing by the patient by proper contraction of the diaphragm. Okay, what else? What is one more effect which can produce bronchodilation of xanthines? All xanthines, all phosphodiesterase inhibitors. They have what is called as anti-adenosine effect.
Yes, sir.
Anti-adenosine.
Yeah, increased catecholamines.
Yeah, adenosine is the one which suppresses the release of endogenous catecholamines. So by suppressing or inhibiting adenosine by its anti-adenosine effect, it releases more amount of endogenous catecholamines. So these endogenous catecholamines can produce directly bronchodilation, isn't it? Catecholamines always, they are adrenergic drugs. They produce adenyl cyclase stimulation and bronchodilation. So the multiple effects of xanthines to produce benefit for these patients with respiratory disease. But what are the concerns if the patient is on these xanthines?
They are more prone for dysarrhythmias.
Dysarrhythmias when we use with halothane.
Why dysrhythmias? First of all, directly they can produce dysrhythmias. Yes. And fatal dysrhythmias, even ventricular tachycardia, ventricular fibrillation has occurred. The patient have died. Patients have died when you are injecting aminophylline intravenously. Why?
Because it has a very narrow therapeutic index.
One is narrow therapeutic index. What is the therapeutic concentration?
10 to 20 mics.
Aminophylline, 10 to 20 micrograms per
decil
per ml.
Per ml.
Or 10 to 20 milligrams per liter. Okay, so anything about 20 can be lethal. Yes. So that is why narrow therapeutic concentration. And what problems they can produce? I said they can produce VT or VF. Why?
So because of the anti-adenosine.
Yeah, yes, anti-adenosine. Sudden increase in the endogenous catecholamine levels in the heart. Automaticity. Sudden increase in the automaticity can produce, VT or VF in these patients. So that is one, dreaded complication of these xanthines, especially aminophylline, intravenous aminophylline. That is why, in olden days, that used to be the drug of choice for patients with bronchial asthma or COPD, acute exacerbations. Nowadays, we hardly use aminophylline. That is one thing. And second thing is, you said combination with halothane can produce problems. Why? Why? What is the interaction? This is the drug interaction. Again, very important because halothane may be kept for you in the afternoon drug section. And there they may ask you about the drug interactions.
Reduces the blood flow to the liver cells, so increases the function.
Pardon?
Myocardial depression. Myocardial depression.
No, you are not bothered about myocardial depression, isn't it here? No, one thing you should realize that, halothane sensitizes the myocardium for endogenous or exogenous catecholamines because halothane produces multiple levels of, blockade in the conduction system from SA node till the Purkinje system. And because of the multiple levels of blockade, it can produce multiple levels of re-entry phenomenon. That is why the reason, halothane is known to what we call it as it sensitizes the myocardium for any endogenous or exogenous catecholamines. So because, one is there are two common methods of production of dysrhythmias. One is automaticity, another is re-entry. Now you know that halothane is producing increased re-entry phenomenon. Aminophylline is producing increased automaticity. Now they have a synergistic effect together. So 2 plus 2 can be 10 or 12 or anything. It is not additive. It can be synergistic. So patient will have more incidence of, dysrhythmias. When the patient is on xanthines and you're also using halothane, though we hardly use halothane nowadays, but invariably this question will be asked because in the exam halothane will be there. on your drug tray. So this is the most common drug interaction other than interaction with adrenaline, again which increases automaticity. That is why halothane, adrenaline, halothane, aminophylline is a very common drug interaction. So suppose if a patient is on derifilin, so should I continue this patient on the day of surgery, derifilin, or I should avoid?
Should continue, sir.
If I'm planning to use halothane.
So we can stop at 4 hours before.
No, at least 2 effective half-lives, 2 to 3 effective half-lives, you have to stop. So half-life of these xanthines is usually 4 to 6 hours. So 2 to 3 effective half-lives means it can be about 18 hours you have to stop. So especially if you're planning to use halothane, it is better to stop at least 1 day before. The previous day he can take. So on the day of surgery, you avoid. So at least about 18 to 24 hours. Again, this will be another common question that will be asked for you. So one is with the xanthines, one concern is, fatal dysrhythmias can occur. What are the other concerns? For example, now the patient is on, you have given general anesthesia, he has developed bronchospasm. Can I use aminophylline? Any problem? Other than
awareness, it causes awareness, sir.
Yeah, because it
lighter plane of anesthesia be there.
One is it may increase the requirement of anesthetics. Otherwise, if you are not increasing the requirement of anesthetics, the patient can develop awareness and lighter planes of anesthesia, and all problems of lighter planes of anesthesia can occur. Okay, what else?
Seizures.
Seizures, because it is a CNS stimulant, it can produce seizures, increased seizures activity, and especially in a patient who is non-epileptic patient. So you better avoid xanthines in such patients. Okay, in pregnant patients, suppose a patient who is pregnant and having a cesarean section, you are giving GA, can I use if she develops intraoperatively?
No, sir, we should avoid it because it will cause neonatal seizures.
Neonatal?
Seizures.
So why?
Because of the caffeine metabolite.
Yeah, because xanthines finally they end up in releasing caffeine as a metabolite, and caffeine toxicity in a neonate can produce neonatal seizures. So again, these are the different concerns as far as aminophylline is concerned. And sometimes because aminophylline also will be there on the drug tray, you may be asked what is the dose of aminophylline.
The dose is usually loading dose and maintenance dose.
Very good.
Loading dose under general anesthesia it is 0.5 mg per kg, sir.
The loading dose.
Sorry, 5 mg per kg, sir. Sorry. 5 mg per kg.
Under anesthesia or?
Under anesthesia. No. Regular, normally, sir.
No,
under anesthesia, it is.
When a patient comes to you in an emergency room and you want to give aminophylline, that is 5 milligram per kg body loading dose, and maintenance dose is 0.5
mg per kg per hour.
Under anesthesia?
0.3 mg per kg, sir, and maintenance dose is 0.3 mg per kg.
Why do you reduce under anesthesia?
So because the hepatic blood flow is also reduced under GA, sir.
Because of the narrow therapeutic index, we have to reduce the dosage of the flow.
And aminophylline is entirely metabolized by liver. Yes. Under anesthesia, invariably the cardiac output decreases, the blood flow to the liver decreases. So all the drugs which are getting metabolized from the liver can have a prolonged duration of action. So as you said, narrow therapeutic range. So aminophylline may get retained in the blood because it is not getting metabolized because of the decreased liver blood flow. So intraoperative toxicity of aminophylline can occur. That is why the dose intraoperatively you reduce by 3 milligrams per kg body weight loading dose and 0.3 milligram per kg. Okay, if the patient is a smoker,
then we have to increase the dose. When not under anesthesia, it's 7 mg per kg loading dose and 0.7 mg per kg maintenance dose. Sir.
Okay.
And when the same person is under anesthesia, 5 mg per kg is the loading dose and 0.5 mg per kg is the maintenance dose.
Okay, why this change?
Because smokers have that hepatic enzyme induces.
Yes.
Yeah, because that is another thing which you should have discussed about smoking and anesthesia.
Yes.
Chronic smoking, they induce the hepatic enzyme system. So metabolism of all the drugs will be faster once the patient is a chronic smoker. So that is why many of these drugs which are metabolized in the liver may be required in slightly higher doses.
Yes.
And another thing is chronic smokers and halothane. What is the problem?
Halothane causes halothane hepatitis. So again, chronic smokers will have enzyme
Smokers are at higher risk of developing halothane hepatitis. That is another thing which you should have discussed in smoking and anesthesia. Okay. Now, that is about the xanthines. Nowadays, we hardly use xanthines, but many of these patients can be on deriphyllin, especially the COPD patients. And for that, you should be knowing about xanthines and anesthesia problems associated. Okay, the other thing is, the antimuscarinic agents. So, what are these? And give some example. How does the antimuscarinic agents act?
So it acts by the competitive inhibition of the M1 and M3 receptors.
Okay.
So it inhibits the release of acetylcholine, which causes bronchoconstriction.
No, M1 blockade will reduce the acetylcholine release.
Yes, sir.
What about M3?
It directly acts on the smooth muscle, sir, to cause bronchoconstriction.
First, you should know that in a bronchial smooth muscle, the nerve supply is vagus. So the vagal nerve ending, it will have M1 receptors at the vagal nerve ending, and also M2 receptors there. Whereas M3 receptors will be on the smooth muscle.
Smooth muscle.
Stimulation of the vagus nerve, that is M1 receptors, will release more acetylcholine. And acetylcholine has to act on M3 receptors to produce bronchoconstriction or to maintain the bronchomotor tone. M3 receptor stimulation is very, very important. So suppose in these patients already having severe bronchoconstriction, so if you block M1 receptors, acetylcholine, further release of acetylcholine, you are going to prevent. And if you block M3 receptors, the bronchoconstriction gets relieved and they develop relaxation of the bronchial smooth muscle. So our anticholinergics or antimuscarinic agents, to be precise, they act on both M1 and M3 receptors. So M2 blocking should not occur, isn't it? So what happens if the M2 receptors are blocked?
M2 receptors are presynaptic receptors which prevents further release of acetylcholine. So if M2 receptors are blocked, acetylcholine will be released.
Release more. Can you give an example for M2 receptor antagonist, anesthesia drug? The pancuronium.
Yes.
Pancuronium, specifically, it blocks only the M2 receptors. Actually, you have to use the pancuronium very carefully in patients with bronchial asthma or hyperreactive airway diseases, because it preferentially blocks M2, so more acetylcholine release, and it can narrow the bronchi and bronchioles. You must have heard about another drug, rapacuronium, which has been withdrawn. Rapacuronium. So again, that was the one which was producing M2 antagonism. So what we want is M1 and M3 antagonism. So definitely our anticholinergics or antimuscarinic agents produce this. So how do you classify these antimuscarinic agents?
Inhalational agents.
So they have to be given only inhalation only.
Short acting and long acting.
As bronchodilators, I am talking about. Not talking just antimuscarinic agent.
Short acting and long acting.
Yeah, very good. Short acting and long acting. Can you give examples for short acting?
Is ipratropium.
Ipratropium. Okay, long acting.
Glycopyrronium.
Glycopyrrolate. One more. Tiotropium.
Tiotropium bromide.
Tiotropium and glycopyrrolate are long-acting inhalational bronchodilators. Antimuscarinic bronchodilator. So the patient is, many of these COPD patients can be on these drugs. If the patient is on these drugs, any drug interaction or any effect on our anesthesia?
So neuromuscular blockades would be prolonged?
Muscarinic have no effect. You give actually, when you are using neostigmine, you give antimuscarinic agents to stop the effect of neostigmine on muscarinic receptors. Mainly, they produce tachycardia, antimuscarinic agents like glycopyrrolate or ipratropium. And another thing is dryness of mouth.
Dryness of mouth.
These two are the side effects. Otherwise, hardly any drug interactions. Okay, so it is 7 o'clock. So tomorrow we'll continue. We'll try to finish as much as possible by tomorrow. So we'll have to discuss about the other drugs which these patients can be on. One is patients can be on steroids.
Steroids.
So that is very, very important for us to know. And the patients can be on antibiotics and how these will have an effect on the our anesthesia management. And then we'll go for examination of the patient. And then we'll discuss about investigations and management. Okay. So you people are answering very well. So you have read, I think some notes you have read very well, actually. So, so because I had presented this somewhere, I had given the notes, I had discussed all these things. So you have read very well, and we'll continue our discussion tomorrow. Okay. Right. All the best for tomorrow.
Thank you. Thank you, sir.
Okay. Okay. Thank you. Thank you.